Hello, everyone, and welcome. Whoop, just kicked the garbage can and the cat got scared. Hi, everybody. I'm Amelia, and I use she, her pronouns, and I am the executive director of Shout Your Abortion, which is a nationwide organization working to normalize abortion and elevate paths to access regardless of legality. We make resources, campaigns, and media intended to arm existing activists, create new ones, and foster collective participation in abortion access all over the country. SYA just had our uh, 2026 planning retreat. And one of the things that we talked about, of course, you always got to revisit the mission. And we continue to notice that our mission that I just read does not feel like it adequately represents our international collaborations and how much that has become a priority in our work and how much our hearts and minds are um, just like in constant conversation with people all over the world. So stay tuned for what may be an expanded mission statement at some point. Um, so if you're here, you probably know that Abortion Academy is a monthly webinar series where we speak to one of our brilliant colleagues who takes a deeper dive into their area of expertise. And these sessions are for anybody who's looking to deepen their knowledge, connect the dots between issues happening at the regional, national, and international levels, or just get some fresh ideas to take back into your community. And we've sort of been alternating US-based activists with uh, uh, what we call our Study Abroad series, where we speak to someone who's working on access internationally, as we are today with our friend Suzanne. So just housekeeping stuff. Audience members will be off camera and muted for security reasons, but you will be able to ask questions in the chat throughout the session. Suzanne's going to speak to us for 30 or 45 minutes maybe, and then we'll have a Q&A and Suzanne and I will chat. We do have live Spanish translation available. If you go down to the bottom of your Zoom bar and you click the globe that says interpretation, and you can choose to listen in the language of your choice. Also, today we'll be having our first ever flip translation where our translators will be translating for English speakers a video that Suzanne's going to play that's in Spanish. So be prepared, English speakers, to go find that globe and toggle it to English if you'd like to listen in English. So today we're really excited to hear from activist and physician Suzanne Veldhuis, a feminist activist, physician, and researcher originally from the Netherlands, who's been living in Chiapas, Mexico since 2013. And for the last decade plus, Suzanne has worked on projects related to sexual and reproductive health and access to safe abortion, both in Mexico and internationally. Suzanne serves as advocacy and research coordinator and physician at Women on Web, beloved Women on Web, and is also the co-founder of the Network of Pro-Choice Physicians Mexico. And she specializes in self-managed abortion models and their articulation with the medical sector. So today, Suzanne's going to be sharing some of her groundbreaking research and work with acompañantes and pro-choice physicians in Mexico. And acompañantes are a group, is the name for groups of activists who accompany pregnant people through their abortions outside of clinical settings. And they do so by creating a safe, holistic, and destigmatizing method of care. So Suzanne's going to be talking to us about like why the accompaniment model is why it is vital to center the accompaniment model in the work of expanding access to self-managed abortion, and also how acompañantes and these activists and doctors can potentially work together to build a better system of care. We're really excited to hear from Suzanne today, and we we love to talk to people who are inside of the medical system and researchers who are interested in demedicalization, which, if you're not familiar with that term, I'm sure Suzanne will talk about it. But it's basically just this idea that, I mean, as applied to abortion, it's this idea that like abortion in the United States, for example, is profoundly over medicalized. And most people have an understanding of abortion that it is something that needs to happen in a medical setting. A person requires medical support in order for abortion to be safe. And that ultimately, research doesn't reflect that. Research reflects that abortion pills are safe and effective, whether they're used in medical settings or outside of them, and whether or not a person has formal medical support, i.e., is talking to a doctor during the process of their abortion or not. So the more that we, I think, understand the ways that these medications can be sort of the more that we like decouple them from a medical understanding, the more we liberate ourselves to understand um, paths to community care and support, and to sort of like build this new world that we want to live in together. So with that, I'm excited to hand it over to Suzanne.
Hey, thank you so much for this lovely introduction. I'm super happy to be here. I love Shout Your Abortion. I've been following you for a very long time, and it's been lovely to have had some contact over the years and doing some stuff together. And I'm really, really happy to be here to talk about yeah, my work and my activism and my research. It's all connected for me. It's like different ways of working on the same thing. So this won't be like a super academic talk, but there will be some academic stuff coming through at some points. So I'm going to share my screen. Um, yes, I guess you can see this now. If not, let me know. So I'll be talking about the abortion accompaniment movement in Latin America and Mexico, but also, as you already mentioned, discussing yeah, possible interactions and collaborations between physicians and pro-choice physicians and activists, acompañantes, which was the topic of my PhD dissertation, which I finished last year, and is also very much something that interests me as a person, as I am a physician who is moving in both kind of spaces. So this is why I always start with a short. You already read my biography, but I think it's always really important to understand like who's talking and where why they're talking about this topic. So I'm a doctor, but I'm also an activist from since before I was a doctor. I'm also a researcher since a couple of years, and I'm also a mother. This is a photo of my daughter 8 years ago when we were at the abortion manifestation for almost, I think, about 10 years, a little bit less than 10 years now. I've been friends with a lot of acompañantes in Mexico and have been supporting them as their allied doctor to go to with any questions or anything I can support them with. Um, and showing you here these two photos, it shows like both parts of the spectrum, which on one hand is one of the first, it was the first national encounter in Mexico of autonomous abortion acompañantes in 2018, I think it was. And the other one is a photo of the first meeting of the National Doctors Network we started a couple of years ago. For me, working in abortion care and then getting to know acompañantes, that changed everything for me. It changed my way of looking at abortion, it changed the way I looked at medicine, at my own role in abortion care, but also in healthcare in general. And I've been wanting or have been exploring like these other ways of seeing and thinking about things also through research. Um, so I have always these different these different hats, like my researcher hat, my activist hat, my doctor's hat, my just I'm your friend hat. So this comes back throughout the presentation at some points. So just a little bit of history. I'm sure most people are aware of this, but we are able to talk about self-management because of the existence of abortion pills. Um, as Amelia mentioned, abortion has always existed. But when biomedicine or modern medicine started to exist and then evolved, abortion, just as any other health issue, came under medical control. So it was defined as a medical issue and also therefore treated as something that needed to be under medical supervision, medical control. And because all, let's say, or most traditional knowledges about possible safe ways of having abortions were lost, or criminalized, or suppressed over the last couple of hundreds of years. The only methods that existed were surgical methods, and you needed a doctor for those. And that meant that people depended uh, on medical staff, on legal systems to be able to access safe uh, safe-ish methods, let's say. So this all changed when abortion pills were discovered. Misoprostol was originally, or is still also a gastric medication. It came on the market in Brazil, and both pharmacy workers and women and pregnant people found out it could be used as well to induce a miscarriage. They started using it like that, and that was picked up really quickly by the medical establishment with a lot of worry about like what's going on here. Why are people doing this? This is very dangerous. But it kickstarted both a trajectory of medical research and use, and the widespread, like the spreading of this knowledge throughout communities. At the end of the 80s, there was also another medication, mifepristone, registered in France, was discovered in a lab, not because they looked for an abortion medication, but because they found something that had that as effect as well. And then there was these two trajectories. No? The one that it was within the formal health system, the development of medication abortion with mifepristone and misoprostol as sort of the gold standard, which was unattainable for anyone outside of formal health systems, and misoprostol, which was readily available in most parts of the world, and started to be used widely across Latin America. In the end, both medications ended up on the WHO essential drug list, and in the 2000s and 2010s, all of this enormous range of different models of supporting people or helping people to access these abortion medications, mostly misoprostol only, in Latin America and across the world. So in 2005, Women on Web was founded as the first international online abortion service. In 2008 was the first safe abortion hotline that was founded in Latin America, and that model was quickly replicated across other countries. And those merged or became parallel to what we now call the accompaniment model, and groups that provide accompaniment across the continent. So acompañantes are feminist activists who accompany individuals who have medication abortions outside of clinical settings. And it's models because there is no one specific model. Yeah, I'll come back to that. So when we talk about self-managed abortion, I just wanted to briefly discuss the definition because it's been used for lots of different things. Nowadays, we mostly use the term when we mean abortions that take place without clinical supervision. So outside of formal health systems, without any provider involvement, self-sourced, self-administrated, and we call that self-managed abortion. But if you read, like, if you look a little bit in the literature, but also the way sometimes, for example, doctors talk about it, they mean different things with self-management. So they may be talking about self-management as part of clinical care. For example, someone who has an in-clinic visit but then goes home and self-manages their abortion at home and then goes back to the clinic for a checkup, for example. That's like a self-management aspect within clinical care. And so that's why you can also talk about self-management as existing across this huge range from relatively like very clinical and medicalized with medical and clinical supervision to what in Latin America we call autonomous abortion, aborto autónomo, where the person themselves, the people themselves use the medication without any person, without any clinical oversight. And that can be alone or, for example, with an acompañante. So what I have, what I can speak to is the holistic, we call the holistic accompaniment model in Mexico. It's where I did my research, it's where I live, it's where I have been working with acompañantes for the last 10 years. And just to explain a little bit, like, what does that work like? Like people always wonder, like, what does that look like in practice? So first of all, it's good to know that acompañantes are volunteers. Mostly, it's not their jobs. It's something they do as political action from their political or feminist stance. Um, and the steps are actually really easy. Like this is different in some other countries. There are differences between acompañantes, between collectives. There are acompañantes that work alone. There are those that are in a group. There are those that are form part of an NGO. But mostly contact is remotely, virtually, by phone. Someone passes a number, by WhatsApp or Signal, or by email, or by social media. And it's people asking, like, I need an abortion. How can I get one? So the acompañantes provide information. They provide information like what are the options, exploring what someone needs. And this counseling is usually virtually, but depending on the situation and the acompañante and where the person is, some also do this in person. The provision of medication is within brackets because they do, obviously, for people, the worry is mostly how do I get the pills? Here in Mexico, it's not that complicated because most pharmacies sell the misoprostol without prescription, so we are in a super privileged position. But there are settings in which that is not possible. For example, here in the south of Mexico, near the coast, is a very, very conservative communities where there may be like one pharmacy in a small village, and then it's impossible for that person to go to the pharmacy asking for abortion pills or for misoprostol, which everybody knows are abortion pills, because it would be very dangerous, like on a social level, to do so. So there are lots of different situations, and acompañantes provide information to make sure people can get the pills, and they can also help procure the pills. The accompaniment of the whole process is this before, during, and after until it ends when the person needs it to end. It can end the moment the abortion takes place. It can end even before. It can end months later, depending on what the person needs. Mostly virtual, but in some circumstances, especially if it's more later in pregnancy, it can also be in person. And there is this follow-up, like always based on the needs of the person. Important is that acompañantes also often provide information on if people need access to health services, like how to access those. We know that almost everyone who is criminalized or prosecuted for abortion has been denounced, or I don't know how to say it in English, by medical personnel or by health workers or by people working in the health system. So part of what the acompañantes do is help prevent this possible criminalization. Oh, sorry. Going to the next slide. And this is a little bit like a long list of characteristics of what does it make what makes the accompaniment model the accompaniment model? Now, these are some logos. They're already old. Lots of groups have new logos in the meantime of some of the collectives here in Mexico. There are hundreds. Every state, every municipality has their collective. And they all have their own way of working, but they have some overarching characteristics, which is that it's person-centered, and that doesn't mean what it sometimes means when we talk about person-centeredness in health services. There it usually means like you treat the people nice and you don't discriminate and stigmatize them. But here, person-centered means like the accompaniment is adapted completely to what the person wants and needs. So it can be completely different from one to another person. It's also completely situated. So that means that uh, it takes into account the needs, the possibilities, the circumstances, the desire of the person who's being accompanied. And the horizontality of it, besides that there is no provider like client or patient relationship, is also in recognizing or acknowledging that both parties, so to say, have their own expert knowledge. So in that sense, like the acompañante is just another person who happens to have information about abortion pills and is willing to share it. And the person needing the abortion is an expert on her or their own life, their own body, their own circumstances. And like this exchange of information makes what accompaniment is. It's based on trust. There's no asking about reasons. It's respecting autonomy, which also sometimes means respecting that people make decisions you may think are not good for them. But it's uh, respecting autonomy is also respecting that people can and need to decide about their own lives and own bodies. Um, Placing the feelings at the center, so the emotional complement is a very central part of the model. So this doesn't mean that accompagnants are psychologists and like give therapy. It just means that there is, they often say like the physical part, that's the easy part, like the medical, the how to take the pills and like what are the physical effects, like that's not what's complicated. What's complicated for people because they are in situations where abortion is stigmatized, where they may be criminalized, where they have to do it alone, where they cannot talk to anyone else, where they feel guilty. They may be Catholics and think they go to hell, like this whole set of feelings around abortion, usually not about the abortion itself, but the circumstances that makes that this emotional complement is so important. The flexibility, it has to do with the situatedness and the person-centeredness. Destigmatization is also a very important part, and this is where like the political, um, um, how you say it, like the politicalness of the model comes into place. Um, it's changing these ideas about what abortion is, if it's good or bad, or like all of these stigmatizing ideas people have that make them feel worse during the process. So it's like this work with them to re-signify, maybe in some occasions, their abortion, to make it maybe sometimes even transform it into a positive experience. It's deeply political. I've mentioned the prevention of criminalization. Often the accompagnants also provide economic support, for example, by supporting someone who needs an ultrasound or by donating the pills. And they ensure safety in um, talking about safety in something that goes beyond the physical safety. You know? So it's providing stigma-free information, is collaboration with health professionals to make sure that people can access the care if they need it or if they want it, and things like ensuring there's no coercion. And all of this together is a way of expressing feminist ethics of care. So what the complement model is based on, like the idea like this, we can do this even where abortion is not legal, because this started when abortion was still extremely restricted in Mexico and in other Latin American countries, is this idea, and this is also some like a discourse that was created that providing information and like accompanying someone is legal even where abortion is not. And I put a little asterisk there because that's a big difference with the US because the anti-rights groups have also paid attention. And that's why now you have in some states these laws that do not go after the person having the abortion, but after the person who's providing information or just accompaniment or being aware of the abortion someone's having. So that's a significant difference between these settings. This is also in depends on different countries, no? So I wanted to show you two short clips from a documentary which is called Entre Nosotras, Memoria Histórica de Acompañantes de Aborto en México. That's between us, the historical memory of abortion accompaniers in Mexico. It was made in the pandemic by one of the larger, well, not larger, but an important collective called the Línea Aborto Chiapas. They are from the south where I live, and they visited different activists, accompañantes in different parts in Mexico to talk to them about like what is accompaniment. I just wanted to show you two short clips. So this is the part where we go from Spanish to English. So if someone needs to go to the translation part, this is the moment. It's like half a minute and the other one is like a minute. There we go. What happened there? Sorry. Right.
No solamente acompañamos abortos, no acompañamos abortos amorosos, acompañamos un proceso, nos preocupamos por el bienestar emocional y psicológico de la persona que aborta. Inclusive en estos espacios donde ya se puede acceder a un aborto, no significa que no va a haber estigma y no va a haber violencia, ¿no? O que no les van a preguntar el por qué o cómo o les van a juzgar. Entonces, el papel de les acompañantes va a seguir siendo el mismo, que es acompañar a quienes quieren abortar en un espacio seguro, amoroso y no violento. Porque las acompaña.
So that was a very short clip in where she describes like what accompaniment is and what it can do. And oh God, sorry. And then there is the second one, where the question is where they are describing different acompañantes, like the political part of what and having an abortion can mean. So they're describing all the things we are aborting when we have an abortion.
Damos esas imposiciones sobre nuestros cuerpos y no solo cuerpos físicos, sino los cuerpos emocionales y los cuerpos espirituales y mentales, ¿no?
Abortamos por tomar una decisión sobre nuestras vidas.
Me parece que abortamos el sistema patriarcal, ¿no? ¿Eso en qué se traduce? Abortamos a veces relaciones violentas, abortamos exigencias sobre nuestra vida y sobre lo que tenemos que hacer.
Abortamos tantas cosas cuando abortamos que por eso es a veces un proceso muy duro, porque renunciamos a esto que siempre nos están diciendo que no podemos decidir por nosotras, que no podemos pensar en nosotras y que pensar en ti, en lo que quieres, en tu vida, en tu camino y tomar esas decisiones justo para mirarte solamente a ti es egoísta, ¿no? En este sistema que nos dice que pensar en nosotras es egoísta, pues abortar es mandarlos a la mierda totalmente, ¿no? Y decirles que decido por mí misma, por mi cuerpo, porque es lo que estoy defendiendo, es mi territorio de lucha.
Creo que cuando uno aborta, se aborta a sí misma. Y al mismo tiempo se pare a sí misma. Creo que es una cosa muy loca.
Estamos
Sorry. So those are, I love this documentary. Sorry for the quality, it's terrible. It's better the original version. I think we're going to share the link. You can find it on YouTube. I love this documentary so much. First, like half of them are really close friends of mine, and I just love seeing them sometimes from like there are other parts of the country. And what I like so much about it is that they're so happy. Like abortion doesn't have to be a tragedy. And accompanying is also not something done out of sacrifice. It's something that is done with love. And it can be love for a stranger. One accompagnante, in one interview I did, she said, like it's like becoming someone's best friend for like an hour, and that's totally fine. Um, and then having that connection with someone, with a total stranger to support, and that also rewards is like a reward to you. So that's also like the horizontal part. For me, when I got to know the acompañantes, this is what changed like my view. I was working in an abortion clinic, and I was convinced I was like being a very nice doctor and providing like very nice care. And then I got to know them and just thought like, I'm not like, this is much better than what I'm doing in the clinic. Like, I'm doing my best, but there's also only so much I can do within these rigid frameworks of a health service. And what they are doing is so much more. And if I had to have an abortion, I would definitely go with them before going to a clinic. So that made me like reflect on like what is actually the role of doctors, what should be the role of doctors, what can we learn from them, like talking about quality of care. Yeah, so that's like set off my path. And I also wanted to mention that this direct action is also a way of creating knowledge. And these are just some examples of, on the left side, those are like the first manuals on how, like the one with the rainbow is the first manual on how to have an abortion with pills from Argentina. I think it was 2009 it came out. And then about second trimester abortions, there's another one. There's different like guidelines. There's about how to accompany to empower. There's the systematization of accompaniments, which specifically the socorristas in Argentina did to, which was very important, instrumental in the legalization of abortion. And then all of these like encounters, meetings, exchanges of information, like this constant like getting better at what you're doing as an accompagnante. And it's not just there's imaginaries, like it's just like middle class students who have nothing better to do in the cities. But abortion accompaniment also happens in indigenous communities. So like these two photos below here are from Zapatista, which is political indigenous movement in the south of Mexico, who have their own autonomous clinics where traditional midwives and community health workers use misoprostol, mifepristone, etc. On the right, some academic articles that were these investigations or these researchers were done in collaboration with Global North researchers, with Global South accompaniment groups, on a horizontal way of collaborating and participatory research. And one of the most important studies on self-managed abortion and accompaniment it's called the SAFE study by IBIS Reproductive Health, was created this way, showing that self-managed abortion is super safe and super effective, like something that activists and women and pregnant people in Latin America already knew for a very long time, but you need to prove these things. So then we come to the second part, which is, so what about collaborations between acompañantes and pro-choice physicians? Like, why should we want this? And I think there's a lot of things, like possible positive outcomes. Such as, I think the first thing that comes to mind is like to have more options and to have better access to safe abortion and to have better care, like higher quality of care. Because if you collaborate, people can choose whatever they want. There are people who prefer to have a vacuum aspiration in a hospital. There's people who do not want to speak to anyone, just want to buy the pills, have the abortion, and get it over with. And there's people who want to self-manage their abortion, but feel safer if they can go for a checkup with a doctor afterwards, even though it's like not strictly necessary. So for all of this, if there is collaboration between the activists who accompany these people and the physicians, I'm talking about pro-choice physician because I'm not even going to discuss all of the conscientious objectors and the physicians that treat people horribly. That's a whole other group. Of course, we would love to have collaboration with everyone, but let's start with the physicians that at least are pro-abortion. So you can imagine, like, yeah, like all of these options that are just available to people and like you can access without any problem. You can have exactly like the abortion care you want, you need. But there's other like positive outcomes as well, or possible effects. So talking about demedicalization, by for me, it has worked like that. Becoming in contact with acompañantes has taught me a lot about my own non-central role as a doctor, and understanding that medicalization is, first of all, unnecessary, and second of all, an important barrier to access. So like this movement towards demedicalization for doctors. But then there is always this exchange of information, so learning from each other. Because at one point I was very much into demedicalization and doing all my research, finding evidence that like backed that up to have these arguments with doctors. But then the acompañante said, like, can you please like give us a training on demedicalization, because it's really helpful for us like to know that what we are doing is the right thing. So there's this back and forth, also in advocacy, combining and strengthening advocacy, because you have more views on the topic, not just from one side, but from all sides. In some spaces, it really helps to have a doctor, because doctors have this role in society where they are supposed to have the knowledge, and if a doctor says it, people will believe it. If an activist says it, they won't. So it's like playing with those different roles in different spaces and know that you can back each other up. Overall, just makes the movement stronger. It destigmatizes abortion, and it can also mean mutual care. So being there for each other and know you can count on each other. So there's so much good that could come out of this. So how possible is this? So this was my question for the last couple of years. And I will just share some of the things I looked at in my study. Obviously, this was in Mexico. It was with a specific group of acompañantes in 3 parts of the country. Here in the south, in Chiapas, in Baja California, which is a northern frontier state as well, and in Mexico City, and with doctors from the Pro-Choice Doctors Network. And there were several questions I had I thought I need to answer before I can answer this question, like, how possible is this? Because there are some fundamental differences between those two groups. So here's where it becomes a little bit academic, and then we move away from here. So bear with me. Basically, physicians and acompañantes, they come from 2 different worlds. And those 2 different worlds, what makes it so difficult is that they're really contradictory. Physicians are trained in hegemonic biomedicine. Biomedicine is called hegemonic because it's the dominant version of medicine across the globe. And every doctor everywhere in the world is trained under this like scheme of thought. And biomedicine is not a neutral science. Science is never neutral, but this is definitely not a neutral science. It was developed, or it developed in Europe around the time capitalism came up. That's not a coincidence. It's biologistic, which means that it's and individualistic, which means that it turns every health process or even social processes into a physical thing. It's all biology. So social, cultural aspects, economic aspects, like they're not at first taken into account. It's medicalized, so that means placing all of these even social issues under medical control and definition. It's paternalistic, it's androcentric, heteronormative, classist, and colonialist. And this means that this doesn't, when I say this to doctors, they get up on their high horses really fast because everybody said, no, but I'm not. No, you may not be, but the system you were trained in definitely is. The white male, cis, hetero, middle class body is considered normal, the normal, the standard. This is also why like all medication studies are only on male bodies, youngish male bodies. No, it's also not old and not young people. And everybody else is like a deviation of this normal. This is why it's so important to have gender perspective in health, but also a class perspective, decolonial perspective, etc., etc. So you're trained under this way of looking at healthcare. It also means other knowledges and other models of care are subordinated. So they're always considered less. Traditional medicine, acupuncture, I don't know, any other type of knowledge, activist feminist knowledge, is considered less. And the medical studying to become a doctor is a very long study, as you may know. And it takes place under high levels of hierarchy, violence, and the lack of possibility of challenging these ideas. So what happens during this training is that as a person, you start identifying with this way of thinking. There's a lot of studies on why doctors, for example, here in Mexico, on obstetric violence, and then researchers looked at like, so why do doctors become violent? And it has to do with the way they are trained. There are obviously more authoritarian and less authoritarian versions of training during medical careers, but overall, like this is the common ground. So what happens is that you develop as a doctor what is called authoritarian medical habitus. And habitus is that something, it becomes your normal. So this is the way you think and analyze the world. So that means that when you say abortion to a doctor, the doctor says, even if they're pro-choice, yeah, that's a health issue. It's a health issue. And to be safe, it needs to be under my control because then I can ensure the safety for those people. And this is like the best version scenario. And this is totally contradictory to where the acompañantes come from. They are feminist activists who form part of what author Naomi Brain calls autonomous health movement, which is defined by, it's not specific to abortions, also, for example, around HIV and needle use, like self-use. It's also like another example for an autonomous health movement, but it applies to self-managed abortion as well, which is the community use and control over health processes that were before or are dominated and controlled by the medical establishment by direct, in this case, feminist action. Another key characteristic is this demedicalization, which challenges that control of the medical profession over this process and fights or shifts by doing so these power relationships. And there's also this willingness or this practice of working on the edge or outside of the law. This translates in the accompaniment model, which I showed you. And for acompañantes, abortion is political. It's also healthy, but it's mostly political. So the question I had was like, but what about pro-choice physicians? No, aren't they like nicer people? Or like maybe they have moved away from this hegemonic medical model, which would make it easier to find common ground with their acompañantes. No? So that's the first thing I looked at. A little bit of a weird table, but or a graphic, I will explain. What I did was, so I interviewed doctors and I interviewed acompañantes and had them describe how they provide or accompany abortion care. And then checked those descriptions on a long list of characteristics for like these basic or like contradictory characteristics of both worlds. I don't know if that makes sense. So on the one hand, it's like horizontal from demedicalization to medicalization, because it's not a binary thing either. Demedicalization, medicalization, it's a range. You can demedicalize or medicalize on lots of different levels and lots of different ways, by the way you act, but also where you are, who you are, etc. And then on the vertical, a line is more autonomy, horizontality, like to the corner, and then more up is more control and more verticality. So here is a fictional person, which will be like the most hegemonic medical doctor, like scoring high on everything that is control, verticality, and medicalization. And here will be like total autonomy, total demedicalization. So all of the ones with A are acompañantes, and all the ones with M's are doctors. So the acompañantes are grouped here, and it makes sense because like demedicalization and autonomy is like a key characteristic of their model. So that is clear in most of their descriptions. But there are also acompañantes that do like their control a little bit more and do medicalize a little bit more, because in the end also, like we were all born and raised in society where the only model of care we know is this authoritarian medical model. So we also replicate sometimes, even if we don't want to. And then with the doctors, it was really interesting to see there's like a range. They're definitely not in this corner, like the super hegemonic medicine model. They're moving away from it, which makes me very happy. And there's a couple who are even really close to the acompañantes. Where people are at depends sometimes not just on like their own wishes and thoughts and political views, but also on, for example, where they work. If people work in the newly instated public abortion services in Mexico, they feel like they have much more opportunity to provide care that aligns more with their values. But if they work in a general emergency room where all of their colleagues are conscientious objectors and anti-abortion, and they suffer a lot of violence for being pro-abortion, or the institution puts all of these rules and regulations, like they have very little space to enact another model. Those are who have their private clinic, have more flexibility. So there's all of these different doctors have, and that's something that became very clear. They have less flexibility to do whatever they want because they work within the formal health system. And the doctors that are close to the acompañantes are actually the doctors that do accompaniments outside of their work as doctors. So that's why they're able to move towards there. On the other hand, not all of them have like ideas that align with, for example, the accompaniment model. So that was my next question. What do they actually think about each other? Oh, sorry, it was a typo. So for the pro-choice physicians, there's this range. There are those that are more move more towards like demedicalization and acceptance of self-management, and others who really struggle like with that because it goes against this habitus, like it goes against everything they have ever been taught. So it's really difficult to break from that. So the funny thing is most of these pro-choice physicians say, yeah, like we trust in self-management. We think it's totally safe. Like they all have experience with it. It's super common. So they have all seen patients who've had self-managed abortions and they all agreed, yeah, that like they never have complications. Like it's super safe. But they say, but still, I think it's better with medical supervision because that's for me is like the habitus kicking in. And you see that in this state, like in this testimony, she says, to me, self-management is a double-edged sword. While it can be a very good idea, a very good option, it could lead to complications, although we know those cases are few. But I do feel that if not closely, there should be some medical supervision. So there's like this tension between like, I'm a feminist and I want like self-management and autonomy is great, but medical supervision, like it would be better. They also conceive self-managed abortion as like they totally understand it exists now, but they do have this vision of, yeah, but when we have like clinical services everywhere and it's legal, like then it won't be necessary anymore. Like best thing is with the doctor. And then there is most of the doctors I interviewed, and these are pro-choice doctors who form part of a pro-choice physician networks, or they're the most progressive of the progressive doctors in Mexico. Most of them didn't know that acompañantes exist. And the ones that did, they mostly describe them as like, yeah, it's really great what they do. Like they can help me in a sense that like I can provide the service and then like they can accompany them throughout the abortion. So as complementary and not as like a valid alternative option, for example. And they clearly describe abortion as medical. For the acompañantes, the main issue, they don't trust doctors and they don't trust the medical system. And that is because they have had so many bad experiences. Like healthcare in general is not great. Here in Mexico, there's a lot of violence there. And then when talking, like, there's even obstetric violence when you deliver, when you have have a birth. Imagine with abortion, there's a lot of stigma, there's discrimination, there's violence in the health services. And they also mentioned this lack of knowledge of doctors. They say there is this discrepancy between doctors pretending to know it all, but we are actually like the experts on abortion care. And the doctors do admit that they weren't trained on abortion in the medical training. But they say, yeah, I wasn't trained, but still I think it's safer with me because I'm a doctor and I know about these things. So there's like this, for me again, is the habitus kicking in. They also, acompañantes, also describe like these kind of power dynamics and knowledge hierarchies. Like they feel very frustrated about doctors like owning abortion knowledge, while they and pregnant people and women having abortions are the actual experts on self-management. And they don't see them as themselves as central. So they see like they say like we are just another option. Like we don't want everybody to have self-managed abortion. We just want everybody to have the abortion they want and they need. And we can be part of that to make that happen. And they mentioned they do see value in collaboration, but not in integration. So that we do not want to be part of the health system because that would limit us in our actions. And for them, abortion is deeply political, as I already said. And in this testimony, she describes these knowledge hierarchies. She says our doctors are not trusting women's words, not taking into account their whole being as human beings. It's a terrible abuse. And doctors have always believed that they have all the knowledge and experience in the world and all the power to do whatever they want with women's bodies. I think what comes next, I saw this video this morning. I thought it was hilarious because it goes right into this, what I'm describing right now. There is now, at this moment, a conference in Bangkok on abortion care. And it's a very medical conference, but there are also activists present. And This is what happens when doctors are talking about self-managed abortion. Yeah, so I just wanted to add that because I thought it was hilarious. It's like it's precisely it like this is what happens. Self-managed abortion is something that activists and pregnant people have been accumulating experience and knowledge over the last 30 years. It's relatively new that it's been discussed in medical circles, and then when it does, like it's immediately appropriated and placed again like under medical control. So yeah, the activists like, oh my God, look at them. So you see there is a gap between those two worlds. That is not easy to close because it's very understandable that the gap exists. However, there are examples of activist-physician interaction. So I tracked a little bit here in Mexico, the type of interaction that exists, basically ranging from like starting like short, punctual interactions where there's some sort of first contact. It's also because there didn't used to be almost any contact between acompañantes and physicians in Mexico, like very, very little, like more on an individual level. But since legalization has been happening over the last couple of years in different states, accompaniment groups have like tried to seek out the health services to try to set up referrals and to also monitor and make sure like the services are actually providing services and a high quality of care. So it is like this approachment. Then there's sort of a next level, which is references. And this is the reference of cases by acompañantes to physicians. So this is very common throughout Latin America. So many groups have like identified like this is a physician I can send someone to. They will not treat them bad. They will not treat them bad. They will not overcharge them. Like they can do the checkup. Like this, like they're to-go-to physician. And then there are more close collaborations that are alliances where there are like multiple of these like mutual benefits going around. Can be like resolving doubts, the bilateral referral of cases, so not just accompañantes to physicians, but also physicians to acompañantes. Mutual support, obtain medications, the invitations to participate in events like in more advocacy or trainings. And there is like this version where it is to be or to have an allied doctor, which are relationships that are much more close, based on trust and recognizing each other as allied activists who share a feminist political stance. So in that group, very, very, very small group, like these differences are fading away. But there it's more the exception than the rule. So I'm almost done. One part of my research for my PhD was, besides like trying to figure out all of these, like where are we at and where are the differences and how are we, like what do we need maybe to cross those gaps, was a workshop. I developed a workshop methodology. It's available like as a small booklet, both in English and in Spanish, or online in PDF. And the workshop methodology was developed both for research, but also as an intervention, because one of the things I noted from the interviews was that basically they don't know each other. The acompañantes have an idea, very correct idea, about the medical profession in general, but actually know very little pro-choice physicians. And the physicians, they don't know any acompañantes. So I thought like first step is like they have to get to know each other. So it's much easier, or it's much more difficult to hate someone if it's an actual person. And I'm sure there are common grounds, but let's see what happens. So we did these workshops, getting together the doctors and acompañantes. And some really interesting things happened. There was a total clarity on that they were all interested in building alliances because they have common goals. Like they're all there and doing this work voluntarily or part of your job because they want people to be able to have safe and quality and nice and loving abortions. Like that's not the issue. The issue is that they have different ideas of what that is and how to get there, but they all understood, like they were all motivated to find ways to work together. And they connected, and it's a bit sad some hand, but they connected on recognizing that in other parts of their lives, they are not different. So in this workshop, were all cis women that participated. So all people who have had suffered gender-based violence throughout their lives, in their works, in their careers, and they recognized each other in that. Like we're the same in this, like we're different on that level, but we are also like all people who suffer from the same patriarchal system that we are trying to fight in some way. So there was this awareness and mutual recognition that came out of the workshop. The clear obstacles to working together was, they all mentioned, like not knowing each other. Like if you don't know each other, like you keep your prejudices and your ideas and you don't move away from them. The coming from the two worlds. For the acompañantes, what they call this false superiority of physicians and the lack of overall knowledge without recognizing like the acompañantes' expertise, and also unfulfilled expectations in the sense that when collaborations happen, like it doesn't mean that they are immediately like perfect and nice and everybody does what the other expects. Like it's difficult. And then on the other hand, like what are facilitators is getting to know each other. Communication, openness, willingness, patience, horizontality, very important. This mutual recognition of like everybody has their role. We need it, like we need all of us. It's not one role that is the most important or the one that cannot lack. Like we are all important, and the ones that are in the center are the people having the abortion. So that was like, if that idea is clear, that really facilitates collaborations, working on prejudices, and noted very clearly a shared feminist political stance. So it's like another way, more positive way than mutual recognition in having experienced violence, a more positive way of like recognizing each other in a shared political stance. The main obstacle is the medical authoritarian habitus, because that is what dictates like the thoughts and the actions of doctors, and it's very difficult to break away from that because it's a process of constant self-evaluation, redefining, seeing things from another point of view. So that requires a lot of deconstructive work, but it helps to have the same objective. And also, one of the conclusions was, like we may not, like the aim or the ideal is to have like these synergies where everybody is just like nourishing each other and everything just becomes amazing in these amazing multifaceted collaborations. That'd be great, but there is also this acceptance of that, like that may be far away, but having like more concrete collaborations on specific points, like that is already a start, and more than what we used to have. And like from these collaborations, like new things can develop. So yeah, that was it. Are there any questions? This says, we have been aborting since immemorable times and we'll keep doing so. Thank you. I'll stop sharing.
Thank you so much, Suzanne. Amelia, I think, dropped off. So I'm just going to take a question from the Q&A. I'm not sure if you can see that, but I'll read it
Yes.
out. So I've noticed confusion around the term demedicalization, especially since SMA involves medication. Have you encountered this, and how can we make the concept clearer and more accessible?
Yeah, that's super common. So doctors always freak out when you talk about demedicalization. It's like, what? Like, what is medicine not useful anymore? Like, no, that's not what we're saying. Demedicalization, for me, it always helps like to think about it as a range. You can be a demedicalized person, like an activist, and do very medicalized stuff. Like say you have to have an ultrasound before the abortion and after the abortion, and you can only take the medication while you're on the phone with me. And like that is demedicalized person accompanying a demedicalized process, but medicalizing stuff at the same time. And at the same time, doctors can have demedicalized models of care, like or ways of providing abortion care. So to me, that makes a lot of sense. So that's why like like it won't be 100% demedicalized because it's medication we're using. It's produced by the pharmaceutical industry. Some situations, some settings, you need a prescription. It's the only way to get it. So there are things that you don't have, like you can't demedicalize. There are things you can. Depends on where you are. Like if you're in a hospital, yeah, like there's only so much you can do, but there is a lot you can do to demedicalize. Yeah, I don't know if that answers your question. There's a very nice research article which I think is very accessible and explains it really well. It's by Drew Hoffman about demedicalization, medicalization, and she says it can happen like at different level, like on a person level, meso, like hospital kind of level, and then also on like macro, on a nation, international level, and then on different ranges, like in identities. So like the actor can be demedicalized or more medicalized, but also in practices and in discourse, because the words you use can also be like medicalization is also placing things under medical discourse. So it's like talking about uteruses instead of wombs. Or I don't know, like in English, I find like English in general uses a lot of very medicalized terms for everything. I was really
Yes,
surprised.
absolutely.
Yeah. But yeah, like the way you speak about things, yeah, can be more or less medicalized or demedicalized. Yeah.
Can you guys see me and hear me?
Yes.
Yes.
We can see you
Okay.
and hear you.
Hi, sorry that happened. I don't know am I like still working? Okay.
Yes.
You're good. So
Okay.
there's one question in the Q&A. I don't know if you can see that. I'm happy to read it.
Yeah.
Okay, so someone is asking, how can we American activists help bridge the connections between doctors and activists here in the US?
Yeah, so I think the first step is like getting people in the same room. And what I found is that it's sort of an unfair situation in where activists are required to have a lot of patience and because they are often, and this is not like to talk bad about doctors, but doctors are not usually political people, so they don't get to abortion like from a political point of view. Like they start working it because it's like it's healthcare and because like they think it's important people have access. But activists come to it like as a political issue, so they are often like much further ahead in their thinking about things, and so getting people in the same room, but in a way that you don't reproduce like these hierarchies. So, for example, that's why these conferences are always awful because it's always like these like doctors speaking on the high stands and activists in the like in the stands listening and being frustrated. Like that's not a good space. What was really nice in the workshops we did was they worked together around like defining what is safety and what is quality of care. And then to see like that they have a lot of ideas in common and a lot of things that also are different, but like understanding where you're coming from. And it doesn't require like this notion of knowledge. No, it's like um, what we also did were social dramas. So we did some acting where the doctors were asked to act out like an accompaniment scene, and the acompañantes were asked to act out like a doctor scene. And like that, placing yourself like in someone else's shoes, it seems so simple, but it really works. Uh, so like that really created that awareness. So I think like these kind of spaces where you can work together on like a task where no one feels like not recognized in their role. But it's not easy. But I think like that's the first step, like to get together and do stuff together, and start seeing each other as people, persons, individuals, and um, yeah, find this common ground. That really
It's the
helps.
first step in like doing everything we have to do to survive the future, I think.
Yes, totally. Yeah, yeah.
Um, Thank you for that incredible presentation, Suzanne. That was like really just articulated so much, like so many themes that I think that SYA is like sort of obsessed with, and you did it like really beautifully. Uh, I love how you. I'm curious, in the chart where it's like the dots, where is your dot?
I didn't put myself in there. My dot is very like it's also interesting for me. I do not call myself an acompañante because I feel
Mhm.
I cannot be because I'm a doctor.
You can't unknow what you know.
Yes, but also I cannot undo my role in society.
Yeah,
Like
yeah, yeah.
I can be an acompañante if the other person doesn't know I'm a doctor, then it might
Right.
work. But the moment they know I'm a doctor, they are going to assume that everything I say is totally correct and right and amazing, and
Yeah.
like the whole horizontality disappears the moment I
Yes.
assume my doctor hat.
Yeah.
And that is because the interaction changes. So and just
Mm-hmm.
like I do sometimes accompany people,
Mm-hmm.
uh, but like I'm a doctor who does accompaniments outside of formal health settings.
Yeah.
Yeah, so yeah, I cannot undo my identity.
Yeah.
And I think like that's fine. Like I'm a doctor with like my feet in both worlds.
Uh-huh.
And it's like the privilege I have, and the role, like I feel like that can be my role, like to
Mm-hmm.
talk to activists about, yeah, I know doctors can be difficult, but you have to understand
Yeah.
like where they come from, uh, and why they think the way they do. Um,
Yeah.
and yeah, just I sometimes also very frustrated, but th that doesn't help change them.
Yeah, totally.
And then on the other hand, like I can talk to doctors about self-managed abortion, about acompañantes, and like they will listen to me at least,
Mm-hmm.
while they would never listen to maybe an activist talking about it. So
Mm-hmm.
I can like leverage
Yeah.
that role in different spaces. Um, so yeah, but I sometimes wonder, like I'm not working in clinical services at this moment. I sometimes wonder what if I were to go back, like
Yeah.
the consultation room, like what would my consultation look like? Like I think I would
Yeah,
totally
totally.
agree. Like how would I? Because I don't want to do it anymore the way I.
Right. I mean, is there,
Yeah.
this is so interesting. It's like answering a lot of the questions that I had about how you sort of like split the world yourself. And yeah, I guess because so much of it is sort of rooted in like positionality, to use a jargony word, it
Yeah.
does, I can see how you would feel like you couldn't go back or
Yeah.
something, or like it would be very difficult. I wonder also if like um I mean, I'm assuming that doctors like get mad at you. Like people have such emotional defensive
Yeah.
reactions to this. Are you seen as like a
I'm sure they
rabble
do.
rouser who's like, a traitor to your profession?
Probably.
Yeah.
I don't know. I've never been told so, like to my face, but I know there's like people that I'm sure they
Yeah.
don't like me very much.
Yeah.
I don't really care. Uh,
Yeah.
um, yeah, how to say, yeah, I don't know. I'm generally nice to people, so
Yeah. Yeah.
yeah.
So
Um,
I wanted to ask, like, oftentimes in Abortion Academy, I find myself like, I don't know, not it's like in no way that I want to play devil's advocate, but I feel like often I'm listening to really smart people talk in a way so that I can um, be more prepared to talk to people who are like less on the level that I am, you know?
mhm.
And so, like, a question that I have is like, when doctors are making points that are like, look, a hierarchy is bad, like, or like the medical the hierarchy within the medical system is bad. There's like medical racism, like damage is done there, but like some medicalization is good.
Mhm.
Um, uh, or maybe they say to you like, it's, if you want to do things in a non-hierarchical way, that's totally good. But at the end of the day, sometimes a person is hemorrhaging, and it's a good thing that you understand hemorrhage.
Yeah.
Like, how do you answer what you see as like the most kind of evolved form of like resistance to
Yeah.
demedicalization?
Yeah. Yeah, well, that's the whole thing. Like, it's not like deleting medicine.
Yeah,
It's just
yeah,
about like let go of control. Like,
yeah,
why should you decide on what abortion care looks like for someone?
right.
I think abortion is like the easiest thing because it's just so easy to have an abortion. Like
Yeah,
there are medical things that are like a lot more complicated and where it would be very much more difficult to see
yeah.
how you could take away that
Right,
control
right,
from
right.
doctors. But like abortion is so easy to
The
have an
doctors
abortion.
took control from us,
Yes.
like the fact that they're so
Yeah.
insistent that it is in the medical purview is like ahistorical.
Yes, totally. And it's like it's funny, like how to say this without being rude. So the where I live here in San Cristobal de las Casas, there's a lot of like more alternative thinking, hippie-ish kind of
Hmm.
thinking going around.
Yeah.
Um, and there's a lot of rejection of medicalization
Hmm.
or medical services in
There's lots
general.
of like crystals and shit.
Yes, totally and stuff. Yeah. Um, and I totally understand that because the medical services are extremely violent. Like
Yes.
I worked 1 year in a public hospital and I broke
Oh,
in a
yeah.
million pieces. And I was
Yeah.
like, what am I going to do with my life? Because like my political view doesn't let me work in private services. And
Hmm.
but I'm not able to survive in public services
Yeah.
because of
Yeah.
witnessing so much violence,
Yeah.
malpractice, discrimination, racism.
Like specifically
It's
against
awful.
indigenous people.
Yes,
Yeah.
totally. But also like women in general,
Yeah.
anybody
Yeah. Yeah.
that
Yeah.
terrible, 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 terrible. So I understand like this rejection to
Yes.
completely anywhere in the world because like the system, like there are places where it is better and nicer and there's less impunity,
Yeah. Yeah.
but like it all has like
Yeah.
same
It's all
basis.
like on that
It's all
spectrum
by
somewhere.
medicine. Yeah.
Yeah.
Um, but then there's people that say, so everything, all medical services are bad, like medicine is terrible. Let's go back to the traditional
Hmm.
indigenous knowledge of delivery and birth.
Hmm.
Yeah, that's very important, but at the same time, that is not something that is the same as 500 years ago. There has been
Yeah.
500 years of dispossession of knowledge, of
Right.
destruction of
Right.
communities,
Right.
etc., etc., which doesn't mean that the parteras, the midwives, aren't still super important to their communities.
Yeah.
A lot of knowledge, they do. But at the same time, Chiapas has the highest rate of maternal mortality of the
Yeah.
country.
Yeah.
And
Wow.
women
That's
do
surprising.
die all the
Hmm.
time
Wow.
because health services are not accessed or are not accessible. Like it's not their fault. It's the
Yeah.
fault of the health services. But like there is this, yeah, we do need, like I'm very happy antibiotics exist. I'm also
Yeah.
super happy like the vacuum aspiration exists and that we have all
Yeah.
these
Yeah.
medications to detain hemorrhages.
Hmm.
And that if someone wants to have a dilatation evacuation for a second trimester abortion, that they
Hmm.
can get one.
Hmm.
Um,
Hmm.
like we
Yeah.
want, that's the whole thing. It's not one or the other.
Right. Right.
We need all options, but we
Yes.
need that people who have the abortion are the
Yeah.
ones that decide how and where and when
Right.
and with whom and under what
Hmm.
conditions. And yeah, so like let go of that control and just do your work,
Yeah.
which is being there for people and offering good quality care when they want or need it. So
Yeah.
that's like my, uh,
Yeah.
yeah,
Perfect.
yeah,
No, that's like
answer.
really,
A very
that's
long
really,
answer.
is the, I wanted to ask about, I went to San Chris like ages ago, probably 20 years ago now, but it definitely is
Hmm.
like still in my heart as it's just one of those, it's just it is a magical
Yeah,
place. Like you see how it's like become this nexus of like vibes because it's just real, you know? Um, I wanted to ask about like the Zapatista, like community healthcare, like
uh-huh.
autonomous healthcare, and like
Yeah,
how your experience has been of that. And I
yeah,
also am curious, I'm surprised to hear that it's the highest maternal mortality in the country.
yeah,
And I'm wondering if you can say say what your speculations are as to why, or your
yeah.
enlightened, data-driven observations.
Of course. So the maternal mortality is not in autonomous Zapatista
Yeah.
communities. Because they have a maternal mortality of almost zero, while
Oh
they
my
are
God.
in, yes, while they have no doctors. It's all community health workers,
I
and they are in the
mean,
most remote, like poor, all of
yeah,
what you imagine villages impossible. So that's not the
that
issue.
if that's not like proof of
Yes.
concept, I don't know what is.
So, so actually, like my first steps towards questioning my role as a doctor happened with or in a Zapatista community. I started before I started working in abortion stuff. I worked as a trainer of sexual reproductive health for
Mhm.
community health workers. So they were all girls. They were super young. They were like between 14 and 24 in the Zapatista community. And I was always like teaching stuff and like, what am I doing here? Like they know
Mhm.
so much more than me. Because yeah, I know stuff from
Uh-huh.
medicine that is useful like in a hospital, but
Hmm.
not there.
Yeah.
Um, and I remember one day there was this woman who came and she wanted an abortion.
Hmm.
And I was like, oh, okay, so what are you going to do? And they were like, oh, we'll give her misoprostol. Like, oh, really? And I asked her, like, so what does the junta, like the local
Hmm.
Zapatista government, like, what do they think about that? Like, do you have rules or is there a law?
Hmm.
And she was like, the health workers were like, what do you mean? Ask the junta. Like,
Yeah.
why do you think we need to ask them? Like, this is a woman's stuff.
Yeah.
Like, it's women's stuff. Like, we
Yeah.
deal with this our own. Like, why would we
Yeah.
ask them? And I thought that was so
Yeah.
hilarious. I was like, oh yeah, you're so right. There I come with my like
Right.
my way of like yeah,
Yeah.
way of
I
looking
mean,
at
there's
things
so much projection in the
completely.
way we show up and help other people, and we cannot ever delete our own
Yeah, where you come
personal,
from.
yeah, where
Yeah,
you come from. And
yeah,
I mean, I think that another, like the flip side of that, I think I could see it being difficult to be an activist, whether you're like full on claiming the mantle of acompañante or you're just like doing abortion support somewhere like in the States. Say you're like working at
Mhm.
a helpline. Um,
Mhm.
uh, I could see it being very difficult if you are a person who has had like profoundly damaging experiences in the medical system
Yeah,
to stop yourself from projecting that
yeah,
onto another person.
totally.
And I could see that being very problematic as well. Although, I think that um, the doctors projecting onto people like you don't know shit, there's no reason why you would understand your body or like your feelings about this are irrelevant. I think that's like a much larger structural problem,
Yeah.
obviously, and one that has like life and death consequences all the time that we see. But I think that as activists, as we look at building this better new world, that I love to hear you say that, it makes my heart feel so I feel so empowered every time we hear from a brilliant person who is like, no, we not only are we going to be okay, we're going to be better. And like it, makes me makes me cry every time, which is something that people are probably aware of at this point. But what I was going to say is, I think that it's so important for us as we do this work to check our own projections all the time so that we're not just kind of doing the same shit in a different way, and like
Mhm.
constantly centering the abortion seeker, centering the person. And that might mean that they are someone who is profoundly anxious about not consulting with a medical professional. You know
Yeah.
what I mean?
Yeah. Yeah, no, I completely agree. I think like I keep repeating it in every space I am. Like abortion is so safe. Like you can do
Hmm.
so many things
Yeah.
like wrong and it will still be safe. It's
Yeah.
really difficult to not have a safe abortion. And it's like it's
Yeah.
not the abortion, it's the lack of access to a health service when you need them. That's the
Right.
issue,
Right.
not the
Right.
abortion itself.
Yes.
And then even like those, when do you need health services? Like almost no one needs health services, like very,
Yeah. Yeah.
very,
Yeah.
very little people. So that I'm also not worried about that. But
Hmm.
what I really like about like the acompañantes, or at least like I'm also a little bit biased because like I think I know the nicest ones.
Uh-huh.
I'm not sure, like I'm sure like the accompaniment world is also like an entire world with a lot
Yeah.
of different ideas and
Yeah.
stuff
Yeah. Yeah.
and ways of working. But like and these like in the sort of the beginning years there were so many of these like encounters and get-togethers where there is this active rethinking of like what are we doing,
Hmm.
um and as doctors we're not used to do that, we're not
Yeah.
used to doing that as a doctor. Like you're trained and then you like
Yeah.
you
Your whole thing is building
keep
a level of
learning like
knowledge that,
technical stuff,
yeah,
but
building a
nobody
level of knowledge that
ever,
like puts you above people as
yes,
opposed to like, yeah, the
yeah,
opposite.
but nobody ever goes into a consultation room with you to see
What do you think?
like
Yeah.
like are the, I like you rare I think doctors rarely reflect on like their own actions beyond the
Hmm.
technical part.
Oh, yeah, totally.
And then because we're not taught to do that, like we're taught like the technical part is the only part that matters.
Yeah. Yeah.
Um,
Right.
and um, and acompañantes, like this whole reflective process, is part of the political process of being an acompañante. Like
Yes.
it's political, so it's all the time.
Yeah.
Like it's not like their protocols are not the same as they were 5 years ago. Like they have
Hmm.
changed, they've evaluated. Um, like they're critical, like these
Yeah.
collectives where it's like
Yeah.
3, 4, 5, and they come together every week to discuss their accompaniments and
Right.
how was it and what did you feel and like what this
They're
person did, like
evolving.
yes.
Yeah.
And it's like this self-criticism and evaluation, also trying to incorporate self-care, not as a
Hmm.
personal, like an individual thing, but as a like a collective care practice.
Hmm.
Or there's like this whole and I'm not saying like all acompañantes do this, but I do know that like the idea of a lot of collectives is to have that process, like this ongoing process of,
Hmm. Yeah.
of
Yeah.
reflection. And I
Right.
think that's really unique. And I think that's something we can really like learn
Yes.
from them as health professionals.
Yeah.
Uh,
Yeah,
yeah.
absolutely. I mean, it's kind of like, it's like the equivalent of consultation or whatever that like a therapist would do, where
Yeah.
they talk to other therapists about the cases that
Yes.
are
Totally.
challenging
Yes.
them, you know?
Completely. Yeah.
Yeah.
And there, I know that like some places, like some doctors have like these group. I hear in Mexico, I don't really know that. I
Mhm.
know in the Netherlands, where I'm from, uh, where family doctors do have like these intervision
Yeah,
groups
yeah, yeah.
sometimes, but those are the exceptions.
Right, right.
And it's still often about technical stuff.
Yeah, yeah.
Yeah.
I was gonna ask, sort of relatedly, you said something during your presentation about how like you know, the person's feelings are really paramount in an accompaniment situation. And to a medical provider, that's like outside of their purview. Like the feelings are like not on the table. And I think that it often gets lost the fact that like feelings are not frivolous in this situation, like
Oh,
and that like negative emotional experiences lead to much worse health outcomes.
yes.
And I'm wondering if you could talk like just expound on that a little bit.
Yeah, I think so different things. So first, like feelings are so important because abortion is not a neutral process.
Yes.
And it's so as I said, like all of the feelings people feel around an abortion are usually not about like the decision to
Hmm.
have an abortion. Most people are sure they want an abortion, and we know also from research that people do not regret having abortions, and having the abortion
Hmm.
itself doesn't like lead to any negative health, mental health outcomes. But all of the other stuff, the stigma and the
Hmm.
guilt and like the fear, because we
Yeah.
are taught abortion is dangerous, because that has
Hmm.
always also been the argument of the
Yeah.
pro-choice
Right.
movement for a very long time. Abortion is super dangerous. That's why it needs to be legal and under
Yeah.
medical
Yeah.
control.
Yeah.
So that is sort of like
Yeah.
not helping our case, our
Yeah.
own case now,
Yeah.
because people think it's so dangerous. So having all of that fear. So first of all, we know that like on a physical level, being feeling afraid leads to feeling more pain.
Hmm.
So people will like literally suffer more during the process physically, but it also means that people, if they do need healthcare, are too afraid to
Yeah.
go and seek it.
Yes.
So that's why we have people who suffer abortion complications,
Right.
because they're too afraid to go. And if they go, they are treated terribly. So they were
Yeah.
right to be afraid. They were right to be afraid. So I think that
Yeah.
is so a lot of the work the acompañantes do is like around that, like making sure
Hmm.
people do not feel guilty, do not feel
Yeah.
afraid, that they can just live through the process the way they need, feel
Hmm.
supported, and just, yeah, as part of life. Like it's part of
Yeah.
so many people's lives. And then for
Someone in the video.
doctors, I think they're like for doctors, it's also like it's difficult because the care is shaped differently in the
Hmm.
sense that if you have a 10-minute consultation with someone or even
Yeah.
half an hour, yeah, it's not the same as having a continuous conversation with someone over the course of 5 days.
Hmm.
And that also doesn't fit in what medical practice is right
Right.
now.
Right.
And that's why what I said, like, I don't know, like how it would be if I would go back to clinical care, because I know that in the way medical care is shaped,
Yeah.
uh, yeah, you can't dedicate that much time to one
No,
person
it's like
to
a
have
no,
the
it's like
see what like
capitalist anything else where it's
yes,
just
exactly.
like
Yeah.
my father had a stroke a few weeks ago and he's okay.
Sorry.
But we were in the hospital and the first doctor that he saw, we saw a couple of nurses who were great, but the first doctor who we saw, um, it had not even been diagnosed as a stroke yet, but he was having like all of the telltale stroke symptoms. And this guy was straight up like, he was adamant that he did not have time to pull up my dad's chart. And my dad has had at this point heart stuff, he's had stroke stuff, he's on a whole bunch of different meds. And the guy was just like interrogating my freaked out 74-year-old parents and being like, when was the last incident? I don't have time. I don't have time to even like open the computer. And it was just, um, I don't even know what to say about it. But I think that, yeah, it is just a compression that makes everything worse that we see all over capitalist anything else,
Yeah.
except it's like
Yeah.
people's lives.
Production.
Yeah, it's production. It's just like we
Yeah.
got to hit the numbers or whatever. And, that is the opposite energy of like your best friend for a day. That's
Yeah.
like, I am here, I'm
Yeah.
in it with you. I am
Yeah.
in it with you.
Yes.
Whatever, like, if you want to talk the whole time, if you don't want to talk at all, like just
Mhm.
meeting someone where they are and just being present in the experience with them, is it's such a beautiful like luxury that we don't
Yeah.
experience very much in capitalism, because
Yeah.
everything feels like, yeah, it's really, really, I'm sure that people have experiences with acompañantes that they're like, and I hear this honestly, like I love abortion providers. I specifically, that's why I rides really hard for independent abortion providers in the United States.
Mhm.
And they're some of the most incredible, values-driven, like radical people that I know. And often they will talk about, and they practice a real like patient-centered kind of care. Like the best
Yeah.
abortion clinics in the United States are really, really patient-centered. And I think that there is a lot of overlap in like the sort of ethos that you
Yeah.
describe. And I think that probably, I know that they have experiences with people, and I'm sure that accompaniment networks have experiences with people where they're like, the person is like, I have never felt like seen like this before. I have
Yeah.
never felt like um, listened to in a medical situation, which I reject the idea that abortion is a medical situation.
Yeah.
But I'm sure that with accompaniment networks that people sometimes get the feedback of just like, not only was this not bad, but like
Yeah.
this relationship is amazing,
Yes.
you know?
Yes. Yeah. Yeah. That is actually something that a lot of people theorize around. That precisely, like a lot of accompagnantes become accompagnantes because they had an
Yeah,
accompaniment.
yeah,
Because like, oh my God, like I can do this
yeah,
for someone else. Like you
yeah,
don't need to be an expert. It's just like being there for someone.
yeah.
And that's also like sort of the idea behind it. Like you want to democratize this
Hmm.
knowledge so everybody can
Yes.
accompany everybody. Like you don't
Yeah.
have to go to a stranger. Like it's possible if you want to, but you can
Yep.
also like ask your neighbor or your mom or your
Yes.
sister or your friend. And if there's no stigma,
Yeah.
then you can ask anyone and it's so easy. Like you can look up on
That's
the
the
internet.
that's the world.
Yeah,
Let's do it.
that's what we want. That's what we
Yeah.
want. And then
Let's
on the
make it
other hand,
happen.
I totally hear you. I think like I know so many also really nice doctors that
Hmm.
provide lovely medical care. And it's not the
Yeah.
same as the accompaniment, but it's also
Hmm.
like, does it have to be? In
Yeah,
that sense
no.
that like when we think about different roles and different things.
Yeah.
Like not everybody needs an accompaniment like 48
Yeah,
hours straight.
totally.
There's lots of people who just want like to receive the information and the pills and be treated nice.
Yeah, yeah,
And
yeah.
like that's totally fine. Like
I mean, I think that's
yeah,
something I really appreciated about your approach is like you're not trying to say that this is the way it should be for everyone. And
yeah,
that's the
no,
difference between
definitely
you and
not.
doctors, other doctors,
Yeah.
is like they are doing that.
Yeah, and some activists as well. There are some activists who
Yeah,
are,
no,
as
for
you said,
sure.
like they're so there was so much rejection of the medical
Yeah,
system. Like say, like this is the best thing. It's like
yeah,
the thing is like we are not the persons to decide.
right, right.
Um,
That's the
someone
whole
having an
thing.
abortion is
Yeah,
expert on their lives and will know what they need. Yeah, so it should just all be available. And I think um, yeah, so I think that's like also what you said before. Like, I think doctors don't need to feel threatened by anything
right.
like this. And there's also like this whole aspect of like the financing of clinics and
Yeah, yeah, yeah,
all this, like, but okay,
yeah.
take away that, then it's still like it's
It's
not, there's
inseparable,
no,
though, from
yeah,
their reaction, I think, you know?
yeah, I think so. And it's like in the end, there's like plenty of abortions to go around.
Yeah. Yeah,
We'll keep having abortions,
totally.
and that's not bad. That's like part of life. Um, yeah, you just want, yeah, I really want for people to also be able to, yeah, to go to a clinic and
Hmm.
then meet a nice doctor who will treat you
Yeah.
really. And I always think, I also had like a recently experience in the public hospital here where I accompanied my mother-in-law,
Hmm.
and
Hmm.
she had chest pain and wasn't
Hmm.
hard, but like we're still like looking. And then this doctor, he just made an EK. They made us wait an hour. Like if she had a heart attack, she would be dead by now. Um, and then made the EKG and said, "No, the EKG is fine." I asked him, like, "Could you maybe like examine her
Check her out. Yeah.
and then like put a stethoscope on her and like talk to her instead of to me?" And then there's always this argument like, yeah, there's no time, there's so much pressure. And yeah, the like emergency room was crazy, but all of these things
Hmm.
take you so little time. It's very easy to be nice to people
Oh
and
my
just
God.
stay, like look them in the
It's
eye
free.
and say a
It's
couple of
free. It's easy. It's better for everyone.
and you
I
make people
know.
feel so much nicer. I always thought that
Yeah.
that was like the lovely thing about being a doctor is that people appreciate it so
Oh my
much if
God.
you treat them
Oh
well.
yeah.
Like I always said, like the most narcissistic job in the world because people are so grateful all the
Oh
time.
my God. Yeah.
You're
After
just
that
doing your
shitty
job.
doctor, we had like the best doctor experience, and it was just like, oh, like you feel saved by the good ones, you know, you
Yeah,
feel like
and that's a really
emotionally,
nice
you
thing to
feel
do.
so like your experience
Yeah,
is so transformed by someone looking at you and listening to you and taking time,
yeah.
because it's
And
so
you,
rare.
yeah, and you have as a doctor, like you have that power,
Yeah,
even if you
it's so
don't
much
want
power.
it. No, you
Yeah.
have that power with what you say, with what you do, with
Hmm.
how you treat people. Like you have so much power, and then like with great power comes great
Yeah.
responsibility.
Spider-Man
I know.
knows that.
Terrible joke.
Um,
Yeah.
Suzanne,
But
this has been such a pleasure. I can't believe that we went
yeah.
this long, but like no, this was so amazing. It's really just like, yeah, it's an honor to be in this movement with you and like listen to your research, which was so accessibly presented also. Appreciate that. And of course, given the subject matter, of course it would be, but it's like always really cool when academic research is presented that way.
Thank
And yeah, it's
you.
just an honor and a privilege, and you just like made us all smarter and more empowered.
Thank you so much. That was lovely. This is my favorite topic. As I said, I can talk
Yeah,
about this for days. So I'm really happy to have
yeah.
been here and glad that I could
Thank you for
speak
spending
with
the
you.
time with us, and thank you everybody for being here. We hope that you enjoyed yourselves, and everybody keep taking care of yourself in this fucked up world. And we're sending love to all.
Yeah.
Thank you, Suzanne.
You too. Bye.
Bye.